Okay, hello. I am Dr. Lisa Thompson. I'm here today with the research working group for Annie, and I'd like to introduce Dr. Wendy Bauer. She is going to speak with us today about fragranced personal care products that lead to high levels of volatile organic compounds and the exposures that people experience when they use fragrance products. And so we're really pleased to have her today speaking with us. And I will also introduce Dr. Bauer as an assistant professor at the University of Wisconsin Oshkosh School of Nursing. So Wendy, if you'd like to share your slides.
I am here today to present to you my experience really of mapping and continuing to map a research trajectory in my interest related to fragrance products on respiratory health to the NIEHS Translational Research Framework. Next slide, please. So first, I want to acknowledge that this content was supported by my participation in the Environmental Health Research Institute for Nurse and Clinician Scientists under Dr. Jessica Kastner, who serves as PI for that R25. And I also want to thank the Annie and the Annie Research Forum and its chairs. Thank you both very much, Dr. Thompson, and then of course, Dr. Mazel, who it's already been shared, is off doing other wonderful things today. So I'm really appreciative that you spend the time to give us this opportunity to share with one another and learn from one another. Next slide, please. So the learning objectives that I put forward today are to understand research strategies for exploring the role of fragranced products on indoor air quality, describe existing policy implications related to fragranced products and indoor air quality, and then to describe how applying the NIEHS Translational Research Framework can help support the development of a trajectory for early stage researchers. So I aim to do so in providing my own journey to and through my early stages of exploring environmental health and my related specific interest. Next slide, please. So as some of you may relate to, I didn't really start my journey in research with an environmentally focused question. I'm coming from a nursing background. I'm coming from an acute care, respiratory and cardiac health background. And so my initial journey in research really was focused in patient education, and then it grew over time to encompass chronic illness self-management. And as a part of that journey, I received pre- and postdoctoral support working as a research assistant on an NINR P20 Center in self-management, and then completed a dissertation that was focused on the self-management experiences of community-dwelling adults with COPD. That was a qualitative study in which I completed in-depth interviews with 28 participants who resided in rural and urban areas in Wisconsin. And on this slide, I've shared some of the details of that study as they were presented in an article reporting the results of my dissertation. The analysis of findings provided insights to the self-management experience of COPD, and including the role of environmental triggers and socioeconomic status in COPD symptom management, and also added some voice to underrepresented female experience as was currently represented in the qualitative literature at that time, where that experience was less explored related to the barriers and facilitators of COPD self-management. So I was pleased to have the numbers of female participants in the study be in line with the current population-based estimates, around 57% at that time. And so that was really helpful in helping to provide voice to that. In the past, COPD was really largely considered a disease of older men, but it is increasingly, as more research is done, known to be expanding and have an impact on women as well in much greater numbers than were previously understood. I learned that although in general there was a lot of interest in preventing COPD exacerbations, there were not as many empirical studies at the time exploring trigger factors and the risks of acute environmental exposures on COPD exacerbations in particular, particularly when compared to asthma. And so this was a bit of surprise when I first started looking into this area of research coming out of my clinical background, only because for those of you who are familiar with the adult population, we certainly know that this is a very prevalent disease. And so the fact that the research wasn't in line with the amount of patients that are frequently encountered in the acute care setting was very surprising to me. But more unsurprising, what happened for me is my increasing interest in the environmental aspect. So I learned that as a part of this the symptom management, a key piece of what the participants discussed in this study were their experiences with environmental triggers. And this was particularly true with those economically disadvantaged participants, some of whom may have been in more shared living spaces, those who may be living in a larger apartment buildings in which they had less control over the sense and the other environmental triggers that were in their environments. And sometimes this was even from those outdoor triggers that were real proximal for their residents. Maybe that's outdoor burning, but then certainly also in some of the areas, just the larger pollution. So this was something that, quite honestly, when I went into doing the study, I had not given as much thought to. And so out of this study, really was born my interest in exploring the environmental trigger aspect in symptom management and working to begin to align how that interest was going to fit into my overall research trajectory focused on self-management. So when thinking about aligning the existing evidence in which it indicated that health disparities were really more commonly seen in respiratory diseases, and that aligning with the findings that I had in this study, I began to understand a little bit more too about how these are in part due to occupational exposures and those environmental risk factors at the individual and community level. And with that, I just sort of felt my trajectory moving into that direction. Next slide, please. And it spurred a lot of questions. And so I think a lot of the questions that came out of that initial dissertation study was really wanting to know more about the mechanisms by which exogenous and endogenous trigger factors exacerbate chronic respiratory conditions and impact symptom self-management. So I really started to get out of the specific disease focus just on COPD and began to expand a little bit more large into the overall chronic respiratory conditions, those chronic airway diseases. I wanted to understand more about how environmental exposures and indoor air quality trigger symptoms and inflammatory responses in airway diseases. And I really wanted to understand more about the impact of socioeconomic status for this population. What were the internal and external factors that compounded the risk for poor health outcomes in chronic respiratory disease? And lastly, I knew from my education in clinical practice that diagnostic categories in inflammatory chronic respiratory diseases, are challenging. So there's a lot of challenges in individuals gaining so-called accurate diagnoses, and that has a potential impact on treatment. And then certainly we know that there's been a changing diagnostic category in COPD and asthma, considered COPD asthma overlap. And so I really, really started to get very interested in knowing more about the limitations of these diagnostic categories and what more could be learned about their heterogeneity within and across the lifespan. And so this came up for me, particularly in that I did use self-report for my dissertation study. And so I did encounter some of the limitations of those diagnostic categories, and that helped to spur some of that interest. I knew that moving forward, I wanted to contribute to delineating important profiles and pathways that would help us understand more about this in chronic respiratory disease. So I began to ask myself how and who and where was I going to start to learn more about this information. And fortunately, I emerged out of the first wave of the pandemic. So I finished my dissertation in August of 2018. I did a postdoc year, finishing up on the grant in the Self-Management Science Center, and started in my assistant professor position in fall of 2019. And then we had a little thing called a pandemic, correct? So I emerged out of that first wave of the pandemic in March of 21 and was really excited that I was able to take part in a really great pre-conference workshop at MNRS in March 21 that was called a Toolbox for Collecting and Integrating Environmental and Occupation Exposure Data. And that was hosted by Drs. Polivka, Huntington Moscows, Kastner, and Amiri, those who were also involved in the ERIE workshop. And that opened it up to a whole different world for me. So beginning to understand a lot more about environmental health. And it was really during this opportunity that I first learned about Annie and the great work of the neuroscientists involved with the organization. And I just really continued to try to work and think more about how I was going to continue to center self-management with these environmentally focused interests. And so that continued to influence my thinking as I moved forward and thought about opportunities. And then when a opportunity came up to apply to the 2023 ERIE cohort, and that seemed like a really great fit. Next slide, please. So I was really starting at scratch when I was thinking about learning more about environmental health. So I can say we have a lot of opportunities in nursing education or research. At least I did within my training, that this was not a deeply covered territory. And so when I wanted to think more about what were these environmental factors, I was really starting from scratch and really thinking more deeply about indoor air, and quickly began to understand how much I was going to learn about chemistry, because ultimately I hadn't been previously viewing the air when I was working and doing a qualitative dissertation and doing that type of work, thinking much about it in terms of chemistry. But certainly that is what is at play. We have a complex mixture of chemicals in our indoor environment, and really, we have the impact on human health really being impacted by the amount of time we're exposed to it, the particulars of the chemical mixtures, the toxicities, the concentrations, and the way in which that we're exposed to it. And so, we really do spend most of our time in the United States inside. And it is certainly a pertinent issue, not only just to those with chronic respiratory disease, but for individuals overall. Next slide, please. And as I began to think more about the indoor air chemistry and linking that back to my the findings that I had in my small dissertation study, I began thinking a lot about what participants told me about their triggers. And so much of their experience related to triggers was focused on personal care products. And so I needed to learn more about personal care products. And what I began to find is that, certainly they're formulated with chemicals, right? Several different classes of chemicals. This can be in terms of fragrances, antiseptics, additives, fixatives, preservatives, solvents, and they can all, we can all be exposed to these in different ways, whether that's through aerosols, whether that's through direct application to the body, whether we're directly doing it to ourselves, whether somebody in our environment is. And so there's a number of different ingredients, really hundreds of classes of chemicals that can be found within our personal care products. And of issues certainly are volatile organic compounds that vaporize at or near room temperature. And so that's why they're termed volatile. And when they're in the form of these compressed aerosols, which are really the propellants of the personal care products and household products that many of us use in things such as air fresheners and colognes and perfumes and in body sprays and such, it really relates to a great deal of global emissions. And so this is when I started to understand that this problem was much larger than I had previously understood, in terms of first seeing it in relationship to the particular patient population I was interested in, and the ways in which it triggers symptoms for those who are already have a respiratory illness, and started to take it out into a larger scope of picture, into this much larger public health issue that we have with our increasing amount of usage of these chemicals in society. Next slide, please. So recent studies have put forward that fragrant consumer products are now really considered a key source of ozone-forming pollution. So studies from the National Oceanic and Atmospheric Administration, NOAA, have found that personal care products are really contributing significantly to ozone pollution. So this has been identified in major urban areas, but increasingly as studies are continuing also in less populated areas. So this is, they have found that this is generating about 50% of the VOCs and that are not generated by vehicle exhaust. So just a really significantly, increasingly a huge problem that is going to not only, again, impact those with respiratory illness, but certainly all of us. Next slide, please. So when we break down and start really just thinking about fragrance, which is where I'm at in learning more about, again, like the chemistry, so that I can start thinking more deeply about accurate or looking to understand more about contributing to the accurate measurement of fragrance. It's important to know, what's in it. So there's a number of different parts of a fragrance that can be potentially harmful. So we know a fair amount that there are hormone disruptors present. There's reproductive toxicants. There's known carcinogens, and then there's respiratory toxicants and aquatic toxicants. And I'm specifically interested in those respiratory toxicants. So how can those trigger lung irritation? How are they adding to inflammation? What are the different specific types of additives that are contributing to being respiratory toxicants, and what combination of these chemicals are impacting this symptom management? So what sort of potpourri of chemicals are people using in their air fresheners, deodorizers, cleaning supplies, laundry detergents, fabric softeners, essential oils, candles, soaps, colognes, hand sanitizers, and other personal care products that might be found in the home, in the school setting, or in the workplace. Next slide, please. Something that's difficult about getting to know that particular piece is that fragrances in particular are not well regulated. So there are some individual school and workplace policies, particularly focused on reducing symptoms and negative health outcomes for those who have fragrance sensitivities, as well as for those who may have symptoms related to their underlying health conditions such as asthma, COPD, et cetera, other respiratory disorders. But overall, those are largely organizational specific, and the difficulty around the development of policies is related that under US regulation, the listing of individual fragrances is not currently required. So one place that is moving to do more work in this area is in the state of California. So there's a California Right to Know Act in 2020, in which there are going to be an increased labeling of the ingredients due to this legislation, so that fragrance and flavor ingredients will be subject to disclosure, which is new. So I think we're just kind of beginning in the policy world related to these specific chemicals in the United States, and making progress in what can be done to inform and educate people about the specific items, the specific chemicals that might be related to their symptoms. So there's a lot of room for us understanding more about those specific chemicals, the composition that may lead to symptoms and adverse health outcomes, and then being able to communicate that effectively and efficiently with patients and families so that they can actively engage in really avoidance activities and also advocate for themselves in their workplaces and in their school environments to help with really avoidance. Next slide, please. So that's just really a little bit of a background to give you a sense of, what my interests are and where this lies with the exposure to fragrance, its impact on human health, and specifically its impact on respiratory conditions. So those links I'm working to make between this exposure to a known irritant, the impact that it has on the individual, and then also linking that back to what can individuals do about it? So that self-management piece of what are they doing in response to their symptoms, and or what are they doing to proactively engage in different behaviors that might help to reduce exposure. So when I first came into the Erie workshop and we were presented with this NIEHS translational science framework in this format with these rings, I have to say I was a little like, I'm not exactly sure how I am going to engage with it. It felt a little bit overwhelming, lots of shapes, lots of rings. Seems like a lot of really great ideas. I'd sort of read through it on the website as I was working through trying to think about applying my research interest to this framework. And it wasn't at first, I didn't see it, right? But what I came to find out is that it was a really helpful and I think a particularly helpful framework for nurses. And I say this because as I shared in my own journey, one thing that became really clear with me as I entered into my particular area of interest in environmental health, chemistry was I should have, now looking back, I guess should have, for whatever. I just didn't anticipate, how much that would play a big role, how much finding individuals who have that particular expertise, being able to communicate with one another, and looking at finding direct connections between the outcomes that we're seeking to work on, how important that would be. And I think in comparison to some of the other approaches that I've been exposed to and working to plan out research trajectories, I do feel like this translational science framework really works to try to link the specific questions, the specific topics, and bridge a gap between those who might be working on the more bench type questions, as is found in the center circle under the fundamental questions, versus those who might be working more directly in the outer blue ring related to policy and related practices such as that. So I like that it provides a visual to going in this iterative process between and across these rings in order to help us to think about how we can directly link the fundamental questions that we're having with the clinical practice questions to the ultimate policy outcomes, which we all, hope to someday make an impact on. Next slide, please. So as I looked into this a little bit more, I found that the NIEHS has some really outstanding resources on their site related to the framework. And I really particularly appreciate how they have provided examples of translational research stories that really illustrate how the framework can be used to demonstrate the evolution of an idea through the various translational research categories. And I have use this myself when working to think about, okay, what are the key, if I'm looking at my whole trajectory, and I particularly kind of like starting with this this column approach at first, because it's a little bit less cumbersome in my thinking than the circles. I think it's helpful for me to put put it back into the circles after I've thought about it in the columns. Here they're showing a path through, but I've also found it to be really helpful in just thinking about these topics, those fundamental questions, the application and synthesis, as just the columns, and then starting to think about, okay, now what study would help me to answer these specific questions that I'm interested in my overall planned research trajectory. And then to start, I can sort of describe in between, like, well, what are the linkages? What are the connections? Those might be individuals, those might be existing studies that are out in the literature. And so I think that it's super helpful in describing, as they have, in a more kind of full research trajectory. But I think for early stage investigators too, it can be really helpful in starting to link those categories across as you're thinking about the studies that you need to help to move agendas forward. And then these the research stories, which there's just some examples sitting in the background of this overall path that I've put on the slide, are just very engaging and really provide some really nice key points related to the impacts of these particular trajectories and how that links in with the overall framework. So I think that it's something that is useful when thinking about doing the type of interdisciplinary work that we all know is really critical in environmental health, because as nurses, we have our own disciplinary perspective that can help us to directly relate to the health outcomes with our patients and families. But there may also be those other members of the team that are really, even more so than in other areas of interdisciplinary research in nursing, just really critically important as we're looking to, perhaps better understand chemistry, or working with engineers to identify accurate ways to measure what it is we're working to capture. Next slide, please. So this is an example. For those of you who have an opportunity to, I think you might be a good fit for the ERIE workshop if you haven't done so already, or that's something that might be available to you. I certainly encourage you to do so. This is the type of an example, the type of model that we were asked to create and apply and do the thinking to apply the translational science framework to our own research interest. And so I would say when I first started this, I had, I think, maybe 3 times as many shapes on this model. And even since in the time since participating last summer, there's become less words in each of the shapes. There's become less shapes. The thinking is becoming more refined. I know that there's still a great deal more work to do in doing so as I begin to think about charting out those specific next steps. But it has become such a helpful tool to help keep me centered and focused and thinking more about that larger picture and my journey as I move forward. So, I've made a couple of decisions as I've moved through this. So I struggled a lot through my whole research trajectory related to the diagnostic categories, which I talked about a little bit. And I've come to the conclusion that it is really a positive thing for my area research to continue to look at the adult population, even though I know that some of the biggest users of cosmetics and fragrance products are increasingly young women, and we're actually seeing that become younger to young girls. As I move ahead in the short term, certainly, we also know that some of those individuals who are most greatly impacted by the negative impacts, the negative effects of fragrance chemical exposure are older adults and those with underlying respiratory conditions. And so That is the population that I'm continuing to seek to explore and broadening that out outside of those diagnostic categories to include those who are going to self-identify and or diagnostically have on record a COPD or asthma. Because one of the questions that I'm looking forward to understanding more about is being able to contribute to phenotype identification based on the objective measures and then the subjective report of individuals. So I really am excited to think about understanding more about those internal and external factors that help us to better describe our patients, which of course has implications for personalized medicine. And if you go next slide, please. So I think about this in terms to the NIEHS framework in terms of some other approaches that I've been exposed to over time that have been encouraged to help me to think about developing key steps of my research trajectory. And certainly models related to career cartography, particularly those by Susan Beetham and colleagues, have come to mind and are those that I have been directly exposed to the most. And I think there's a couple things that I've noted in my own experience that has been different in using the NIEHS framework versus using, I have an example up here of one from a publication that's listed that there's some key things that between this approach and the NIEHS approach that I have found. And one of it is the linearity, right? So here we have a pretty linear model going straight across, leading from one model to the next. And I have to say, returning to that after having all those concentric circles of the NIEHS was a little comforting, right? Because it helps me as an earlier stage investigator think about one step to another. And so I do think that that still remains an important part of the process for me as I continue to work to gain my ground and to identify my next steps and be able to clearly be able to describe to others what those next steps would be. So I do find that that's very useful and works nicely working in conjunction when I think about the types and the places of the questions that I'm trying to answer in terms of their overall broader impact, which the NIEHS framework is really, really helpful for. So I continue to use these approaches, thinking about this in terms of these 5 key areas of the framework. What are those fundamental questions? What are the application synthesis pieces? What are the pieces of implementation or adjustment? What's the refinement? What are going to continue to be the policy and practice implications? Is that changing, tweaking as I continue to think more about the specific next steps and, what's that overall impact? And, I think overall, the overall mission statement, of course, fits very nicely with these overall destination statements that we have, been, taught and trained to consider and think about. But there is a different, I feel like a different end in mind when looking at it in terms of my overall career versus the body of research and the potential translation into evidence that can really come from applying it to the NIEHS framework. And next slide. I think I'm done. So I went through that pretty quickly, but it leaves some time for questions. I think I saw some things going on, but I think you were doing nice plugs for
I was indeed. Thank you.
Yes.
It's really exciting to see how you've applied what you've learned at the workshop, because I can see its direct relatability to how you're thinking about it as a new investigator. So I just put in the chat, there's a direct link to apply. We're accepting applications until March the 1st. It's going to be in Niagara Falls, a place I have never been. This is a 5-year R25. And so that's our 3rd year. And then I think we'll be on the West Coast for the other years. So please apply. I also didn't say that there are CEs for this, and so there's some, perhaps I'll have to figure out how to get that link for the CE so that you can complete that. Liz, you have
Lisa,
that.
do we have post-test? Lisa and Wendy, I guess the question is for both of you. Do we have 5 post questions and answers?
We do have some, yes, yes. So where would they be located?
I'll send out the post-test evaluation this afternoon. Right
Okay.
after, to the participants.
Oh, thank you. Okay, great. We do have a question. And I think that the question is, some of it you discussed, but how did you choose this topic as your research focus?
Yeah, I certainly, I mean, my training is centered in chronic illness self-management, but taking it further back to that, my interest in respiratory health came in part from my clinical practice, working in cardiothoracic units. So certainly I found post-procedurally that our patients that had underlying respiratory issues were certainly at risk for worse outcomes. But more personally, I first off, I have an entire family, including myself, that's super allergic to the world. So I really consider our allergies a chronic illness. Thankfully, we don't experience like food anaphylaxis, but these types of issues related to just exposures, I mean, are just really pervasive across anything. I did have an allergist once tell me it was great because I wasn't allergic to sterile water. Haha. So, I mean, but then, even more so than that, because that's kind of emerged that linkage that I found between my own experience. But I did, my personal story is that my dad was diagnosed and subsequently died from idiopathic pulmonary fibrosis. And so that really began my a deeper interest into cardiac and thoracic care. First with cardiac because he also had an underlying heart issue, but then secondarily with pulmonary interest. And so I initially, in doing my dissertation, I wanted to study pulmonary fibrosis patients, but was told that that was going to be a hard recruiting process. And I retrospectively agree at the time, maybe not so much, but retrospectively agreed because it is a much smaller patient population. But so that really helped to frame my understanding too of the symptom experiences that are shared across these respiratory patient populations, for sure.
Okay, and Anne, you had a question? You have your hand up?
Kind of a question, but more, excuse me, more of a statement. This, I don't know if you've heard of multiple chemical sensitivity, but I'm pretty sure I have that. I first noticed a sensitivity, excuse me, when I was in high school and my sister used to wear English leather. If anybody remembers that, it's horrible. And I would get a terrible headache and wheezing. And then it was just everything after that. But I'm just so glad that you're studying this, because for many years I've actually said to people, I'm allergic to your perfume. It does not go over very well. It's actually very offensive to people. I actually react if someone's buying Tide. That's how strong that is. And but anyway, but I'm so glad that you're studying this. And I actually went to an allergist, and he's since retired, so he's kind of old school, and he didn't really know much about fragrance allergies, which is kind of distressing. And I'm so happy to see that this is an area of research, because there really is something behind it. And I'll just quickly add that I have noticed, because I'm very sensitive and I react to perfume, I have gone to many, many conferences, and, you know, as a nurse practitioner, we're mostly women. And I have noticed in a big conference room, it takes about 10, 15 minutes for everyone to start coughing. And I don't think people realize that they're reacting to their own perfume and other perfume. So thank you very much for this research. It's very won't say gratifying, but it's very helpful.
We
So
had a
thank
clinic,
you.
and I came from California. Now I've been here in Atlanta for 7 years, but we had a clinic at where I worked for 20 years as a nurse practitioner, where we had a fragrance-free policy. And it was mostly, of course, the employees. You know, we couldn't actually, you know, enforce that for patients walking in the door. But I was wondering if there, Dr. Bauer, if there's like a way to like look at fragrance-free institutions versus not, and actually do some like measurements or something that can quantify the amount of exposure people are facing. And, you know, same with conferences, I agree. Any kind of room where you're mixing with people. I'm also one of those crazy sensitive people to this kind of smell, these smells. But mostly, I mean, they're not even, it's not even just a smell, it's the VOCs, and they're harmful, and they react with tobacco. So if you have people that are smoking and using air fresheners, they're getting a really bad dose of particles that they're breathing.
Yeah.
So I just wanted to ask you more about like your future, like where you want to go with this.
Yeah, thank you for all of those comments. I'll first say that to the multiple fragrance sensitivities is it really does contribute to this overall body of literature, because that's where a lot of what we know about the impact on human health comes from, is from those who are interested in that particular issue. And so it's helpful to have had that work done, and then it can also be impact the chronic respiratory disease literature. I found too, just in, you know, my small dissertation study, and this is what part of spurred my interest in this, is that a majority of the participants who described having issues with fragrance or symptoms, they were very dismissed by their healthcare providers. And so that was a recurring theme, that when sharing, that there was really no positive outlet with their healthcare provider and helping them to make sense of their symptoms outside of justification. There would be recognition, acknowledgement of more known allergens, mold, things of those nature. But when it came to the scents and the fragrances, they were largely dismissed. As far as and then when I think that there's a lot of really great qualitative work that's waiting to be done related to that experience of living what is really, and it's increasingly termed as sort of an invisible disease, right? Living with chemical sensitivity. And so I think there's great opportunities for incorporating either some of that type of approach into understanding the personal impact of living with sensitivities to these chemicals, into more mixed method studies that are looking, trying to obtain more objective measures as well to symptoms for those with respiratory conditions. So I think that there's work to be done with that. And as far as like comparing some of the impact that we see related to fragrance-free policies, what first comes to mind is some of the occupational health work that's been done for individuals working in malls. So what some work that has been done is that individuals working in those places that have either scents piped in, versus those places who don't, or those who are working in the same larger mall, for example, those who are working directly in those stores that are selling those products versus those who don't have had some increased negative health impacts, or report being bothered by them more than others. So I think that I love the idea of bringing that into the workplace. I think another piece where we see that is in work with kiddos with asthma in the school environment. So there's some great work going on related to fragrance-free policies for controlling symptoms for kids with asthma. And so that's really helpful. Of course, we know that, kids are not just little adults. So this work being done in that area, perhaps physiologically isn't as transferable over to the adult population, but it is really good in just being able to talk about the overall potentially positive implications of policy. So thank you for that.
Thank you.
Do we have any other questions or comments? I see a lot of kudos to you in the chat about all the wonderful work. And Anne Marie says that you really applied the translational research framework well to your question. I also became intrigued because I remember being in that workshop and thinking, how would I do this? There was actually, will just share this one thing, which was the asthma example that you showed, and some other examples that if you click on the link in the chat, you might see other examples to use.